conflicts, I should note that I'm a consultant for this company, Vesteck. We all understand the issue about aneurysm repair and EVAR as a solution for this, but the issues that we have not solved are the durability of the grafts and essentially sac shrinkage. We know that these endografts provide value, and I talked a little bit about this yesterday, but I want to talk particularly about fixing the graft in place and trying to solve the problem of continued aneurysm growth, endograft leakage, and how do we solve that problem. In this study done by Bart Muse and several others, they looked at 100 patients that were propensity score matched by 19 anatomic criteria and looked at outcomes at 2 years. And what they found was that there was freedom from type 1A endoleak in the majority of patients. But sac regression, which I now view as success of this procedure, happened in 80% of the patients who had some form of additional proximal seal device, the anchor device, and 50% only in the patients with nothing. Those subjects who had neck abnormalities had no difference in sac shrinkage, so it doesn't help overcome all neck problems. And obviously, the more problematic the neck, the more problematic the problems. But the anchor device is a corkscrew, and it does not have a force that pulls the graft against the wall. This device that you see on the right here is essentially a nitinol suture. And because of the way it's shaped, there is actually a force of this suture on the aortic graft to pull it into the wall of the aorta as it heads through the graft and through the wall of the aorta. This is a device that has a biasing mesh that's pretty easily deployed with the handle. You can see how you can do that on the right, and you see the biasing mesh that affixes the suture delivery system to the wall of the aneurysm itself. This is just a video to show within a silastic tube how the device works. The sutures are actually along the length of the device from the top, and they're actually pulled down into position. And once that suture's in place, it's actually pulling itself and pulling the graft to the wall of the aorta. These devices can be removed and repositioned, as you'll see here. The suture comes out, the position is unfavorable, the biasing mesh is released, the device repositioned, and then the device deployed in this area. And in this video, there are 4 sutures that would be deployed in under 2 minutes. This is literally how simple this device is in terms of deployment. Animal studies have looked at this, and you can see that it goes through the graft, through the artery, and through the adventitia, fixes the device in place. Can be at times a little bit more challenging to see under fluoroscopy than you see here, but it does achieve good apposition of the graft to the wall. Again, just some other images of the graft through the wall. These are some histologic images, and I want you to notice that every place there's one of these sutures, as you see on the top right at about 2 o'clock, you can see that the graft is actually pulled into the wall by these nitinol sutures. The histology also shows that there's good coverage of this nitinol, similar to the way that the graft is covered with pseudoendothelium or with endothelial cells. And you can see again that the device itself easily is covered with endothelium. This image on the right, I think, is a good image of how the device itself functions. You can see that this is the contained portion on the right side that's within the lumen of the vessel, and you can see it actually pulling the graft itself and the metallic structure of the graft into the wall of the aorta to fix the graft and to help seal in the proximal aspect. This is one of the first deployments that was done in Latvia. You can see the biasing mesh has been deployed on this side, on the right side in the image. And you can see As the video moves forward, you can see the device moving out from the graft itself. I'm sorry, I don't have a laser pointer to point that out, but you can see that the suture is out through the wall of the device on the right side of that image, and well positioned, easy to deploy, less than a minute of time. Because there are 4 self-contained sutures, you don't actually need to remove the device to reposition it and to place a second suture. So the biasing mesh is withdrawn, the device is rotated, and an additional suture can be placed. This is some images from the 5th case that was placed in Canada by one of the early investigators with this device. Sorry about some of these images. They're not fluoro feeds. These are actually camera images of the fluoro feed. But what you can tell is that the biasing mesh is easy to push the delivery system against the wall of the graft and against the aorta itself. As you see the tray that has the suture start to move down, you can see the suture come out through the wall of the graft. On again, the right side of this image, you can see 2 prongs coming out, and they fix the device in place and actually pull the graft into the wall of the aorta. This is somewhat different than what is able to be achieved with the anchor device that's previously been used in this setting. So to date, there have been 12 successful in-human implants with 8 different physicians who have participated. There have been no major intra-procedural events, obviously no migrations this early, no leaks were detected, and no suture fractures or embolization, with good deployment of the system. In conclusion then, most surgeons believe that sac shrinkage is indicative of successful endovascular aneurysm repair, and we need to make this happen for patients. The current devices provide this success less than 60% of the time. Improving proximal seal and fixation will improve sac shrinkage, reduce long-term risk, and reduce overall and aneurysm-related mortality for these patients. And the Vesteck SUTURE-TIGHT can potentially provide a rapid, effective, reliable, and reproducible nitinol suture placement to achieve better sac shrinkage and improve fixation. Thank you.